Now, about 80% of the miscarriages happen between or during the first 12 weeks of a pregnancy. And in Africa, it is estimated that about 4.2 million women or miscarriages take place every year. We have an estimated or an approximately 1 in every 10 women experiencing miscarriages. My name is Purity Museo and you're watching My Doctor Show. So what are some of the causes for miscarriages? How can miscarriages be managed and how do we prevent them from occurring? Do stay tuned because Professor Omondi Ogutu will be helping us with that discussion. As always, you're welcome to be part of this show by calling us live through the number that will be displayed right at the bottom of your screen throughout this show. Use the hashtag MyDoctor to talk to us on Twitter at Ebru TV Kenya. And as usual, just before we get started, let's have a look at what's coming up.
I think as a country, we're not doing very well in terms of registries. So you find the actual national data will be a bit difficult to get that what a number of miscarriages we're having. Having had said that, miscarriage is a very common thing that happens. So you find that most hospitals will have some form of evacuation, whether it be medical or surgical, going on a daily basis. At Kenyatta, we have on average 3 to 4 patients who are going to be evacuated on a daily basis. But it's also understanding that these are not all the cases. There are many hospitals, and there are people who also experience miscarriages without realizing that they're having a miscarriage. So, but generally, miscarriages in terms of percentage will occur in about 8 to 15% of all pregnancies. I think the only thing that will really heal the wound of a miscarriage is when you have a successful pregnancy. The arbitrary cutoff is about 3 months. Some other doctors would advise 6 months. It just depends. It's just a preference of your practitioner. But again, you also are going to counsel the woman and see if she's psychologically ready, because if you've had a miscarriage, there's no guarantee that the next pregnancy is going to be successful. As we said, it's 15%, there's an 85% chance. So obviously, there's a higher rate, there's a higher percentage that you may have a successful pregnancy, but there's still the risk that you may still have a subsequent miscarriage. So the 3 months is more or less just for that psychological healing, so the woman to be prepared for the next pregnancy and whatever the outcome of the next pregnancy. But in terms of physically, even in 2 weeks from the last miscarriage, a woman can conceive almost immediately after a current miscarriage. Okay, so the biggest cause of miscarriage, we'll find in about 50% of cases we may not actually get an exact cause for a miscarriage. So if we were to take the ones where we can get a cause, 50% of those will be because of some chromosomal abnormality in the fetus. Those that don't have a chromosomal abnormality, a good number may be due to some hormonal problem. So those are the things like thyroid, prolactin, diabetes, or you have uterine abnormalities. So uterine abnormalities can range from something like a fibroid or what we call congenital uterine abnormalities. So the uterus has an abnormal shape. So those are quite common causes. We have autoimmune disorders. So in autoimmune disorder, I think the most common is the lupus, that's SLE, and people who have what we call this antiphospholipid antibody syndrome. So that will include the things like the lupus anticoagulant, beta-glycoprotein antibodies, and things like that. So people who have those autoimmune disorders are also prone to get miscarriages. Infections can also lead, but currently they're not they don't count for a big percentage of the people having miscarriages. The majority will always be because of some chromosomal abnormality in the embryo. So if you have a known cause, say for example, diabetes, and you think it was because of diabetes, obviously to correct the sugars are corrected, you should have a normal pregnancy. So it's depending on the cause. Now you find like the chromosomal abnormalities, correcting for chromosomal abnormality is not feasible. It would again require very technical ways of conception. So again, it will be doing something like an IVF with doing a biopsy to ensure that you only put back embryos that do not have any chromosomal abnormality. And the challenge is it's quite expensive, and there's no guarantee that a pregnancy is actually going to implant. I think, like, how do you manage miscarriages? Yeah. So in terms of treating miscarriages, so one, it depends on whether it's complete or incomplete. So somebody who has a complete miscarriage with just the psychological therapy and counseling to help her go through, because it's a loss. They feel lost as if they've lost a baby, and it's very challenging. Somebody who has an incomplete miscarriage, it would depend on if she's bleeding very heavily, then maybe a surgical approach where we do an evacuation. But somebody who's having moderate bleeding and is not having any signs of infection, then we can do what is called a medical evacuation. There's some tablets we'll give that will help empty the uterus.
Welcome back. You're watching My Doctor Show, and our topic of discussion today is miscarriages. Professor Omondi Ogutu is helping us with that discussion. Do join us. Call us live. The number to use is 0791 478 990. And now help me welcome our special guest on our Wednesday show today. Welcome, Prof. Thank you so much for making time for My Doctor Show today. Thank you so much. So we could start. Our topic of discussion is on miscarriage. We begin with the basics. Define for us, when we talk about miscarriage, what does it stand for?
Interesting subject for discussion today, because I think it will enlighten most of our viewers on a subject which is mostly misunderstood, with lots of myths surrounding it. And I try and, in the process of the discussion, to demystify a number of things, use simple terminologies and languages so that our viewers can be able to follow. Miscarriage simply means that a woman who was pregnant lost the pregnancy. It's a pregnancy loss.
Right.
Now, I would like us, because in the process of discussion, to not to mix two things. When somebody talks abortion and miscarriage, that basically means a pregnancy loss, but will not be addressing the issue of abortion, because abortion means a deliberate termination of a pregnancy, or what you can put in some parlance is menstrual regulation. So what we're going to talk about is a spontaneous pregnancy loss, which is miscarriage. Yes.
And when you talk about miscarriage and also pregnancy loss, is it one and the same thing, or there's a difference? Because I believe miscarriage happens quite earlier than a pregnancy loss can even occur during late pregnancy. That's right?
Yes, those two terminologies are almost used concurrently, but usually when you use the term miscarriage, you have a cutoff of about 20 weeks of pregnancy, which for the lay people it would be 5 months. Right. But a pregnancy loss simply is a wider scope, because it will go until the time when somebody who was pregnant does not have a baby to take home. So if somebody is maybe about 8 months pregnant and you lose the pregnancy, it might be a stillbirth, so we refer to that as a pregnancy loss, because you don't have a baby to take home. And miscarriage, if I'm to you to maybe expound on that, you can classify it in 3 different categories. One is what we call the primary miscarriage, which means that somebody has consistently lost pregnancies within the first 12 weeks of pregnancy. If you talk of the secondary, it means that somebody has had pregnancies, successful pregnancies, but interspersed with one pregnancy loss in between before the 20 weeks. And then when you talk of the third one, is whereby somebody has had successful pregnancies, but in between it is interposed with a pregnancy loss. And all these, we refer to them as having one partner. So it's not that a lady has got different partners, because different partners brings in a different component in the whole scenario. So it's usually when you talk of one partner and the lady. So then you talk of that miscarriages. And one miscarriage per se is not an issue, because we know that 15...
That's now the tertiary?
Yeah. No, I'm saying miscarriage in general.
Right.
A woman having one miscarriage would almost refer to it as a normal occurrence. Women, 15 to 20% of pregnant women would have a miscarriage. That's known because of the dynamics involved in it. But now when you have more than 2 miscarriages, we refer to that as the recurrent pregnancy loss. And in medical terms, what is most of concern is when somebody has got now recurrent pregnancy loss, meaning that you have lost 2 pregnancies and more. That becomes a medical issue, because now you have to determine why is it that this woman is having a miscarriage, what do you need to do so that you can be able to, as we'll discuss later on, prevent this occurring.
Okay, and you've classified them into primary, secondary, and the third tertiary. What are the main causes for miscarriage? Maybe you could break it down for us. Primary, which is a recurrent, more than one pregnancy, miscarriage, that women experience more than one miscarriage. What are the causes? Do we have similar causes for those 3 categories for miscarriage?
Well, the 3 categories may have slightly different causative factors because of the time factors involved. But if I am to go through it maybe step by step, there are quite a number of causes of miscarriage. And some of them are more technical, some are easily understood by most of our people. But I'll take you through them this way. One is anatomical problems in the womb, meaning that there's abnormalities in the womb. Maybe the structural abnormalities, how the womb is, or what most people understand, maybe you have got fibroids, which brings a bit of what we refer to as mechanical distortion of the uterus. That now makes it not an ideal component to carry a pregnancy, and you may be able to have problems of pregnancy loss. Number 2, you may have problems associated still with the uterus, mechanical also, when you have got weakening of the cervix, which most people have always heard referred to as, oh, so-and-so has got cervical incompetence. But the correct terminology is cervical insufficiency, not cervical incompetence. But when the lay people use the word incompetence, we would understand what it is.
Right.
The second other common cause is infections. There are various types of infection, both bacterial, fungal, viral causes, and all these can lead to somebody having a miscarriage. The third cause is what we would call immunogenic factors, such that the body has got a way of rejecting that pregnancy. And these immunogenic factors, some of the things have to do with the lining of the uterus, such that the body almost behaves as if it is rejecting that pregnancy. And there are some components within the lining of the uterus which can lead to the pregnancy which is growing being literally, to use the lay terminology, is being destroyed and almost being reabsorbed, and therefore the pregnancy doesn't grow. The other factor is something to do with the blood circulation process and then the blood clotting mechanism. If there's a defect in that within the lining of the uterus, then the blood flow to the uterus will not be ideal within the lining of the uterus where the baby, the growing embryo is implanted. It will not achieve or get adequate nutrition, and therefore it will be compromised, and that will lead to an early pregnancy loss. The other interesting component, which I'm sure everybody asks every other day, can stress lead to a pregnancy loss? It's a very common thing, but it is true. Stress has now been shown that, yes, it can make you lose a pregnancy. Because the moment stress sets in, it has got that component of disturbance of flow of blood circulation at the endometrial level, which is the area where the baby is implanted. And once that is compromised, you will not get adequate nutrition to the fetus, to the growing embryo rather, and therefore you can easily lose that baby. Other interesting fact which will be of interest to everybody is that, does the male contribute to it? Yes, the male factor is important, especially as one grows older. You are as old, your spermatozoa is as old as you are. And therefore, as you grow older, you are more likely to have defective chromosomal patterns within your spermatozoa. And therefore, when there's a fertilization taking place, chances of having chromosomal abnormalities are much higher. And therefore, the older the man is, the more likely that your spouse may have a miscarriage. And this is something which most people always say, that the man is as good as he is, whether he's 80 or 90. But this is really not true. There's a lot of new information
You're
coming in.
talking about the age factor?
The age factor on the man.
Yeah.
I'm talking of the male contribution to miscarriage.
Right.
The other factor is what we call that the other components of what you call the, like, I'm trying to see the easier way to put it, but we refer to them as antiphospholipid antibodies. These are some of what we refer to the connective tissue disorders which can occur within the woman, and this will have a negative effect in ensuring that the fetus, the embryo which is implanted, may not have an ideal environment to be able to grow, and therefore they are compromised much earlier. Then you end up with what we refer to as a blighted ovum.
Right.
So these are some of the various other components of what can lead to a recurrent pregnancy loss.
Right.
People will ask, okay, there are also the physical effect, a direct effect like a mechanical trauma. But you know, that is more of an ideal thing, or means of a grave event which can occur. Like if you have an accident, you have fallen down, maybe that direct impact can disturb the endometrial lining, and therefore you can easily have a miscarriage. Like in situation where people have had a road traffic accident, or you are driving and you have got a sudden impact, that can lead to a pregnancy loss.
Right.
It is not really what you would call the ideal situation, but these are some of the components which you can be able to get and lead to a pregnancy loss. Yes.
And Doc, you've talked about some of the causes for miscarriage. When you look at the statistics for women, the number of statistics for miscarriage right now, not only in Kenya but globally, they are really high. Maybe we could get into the common ones, the common causes for miscarriage, or Doc, what you've talked about, all the ones that you've mentioned, are they the common causes for miscarriage? Because you've talked about so many issues. Which are the common ones, especially in an African setting?
Interestingly, the common causes of miscarriage are unknown. That's the interesting thing. Nearly up to about 50%, between 40 and 50% of causes of miscarriages, you may not be able to pick up the ideal cause of a miscarriage. But we know that the other, what we'd call as the common causes, especially in our setup, would be what I forgot to mention is some of the medical conditions in the woman, like those who have got heart diseases, those who have got thyroid diseases, those who have got diabetes, amongst the many others. These are medical conditions which can compromise the early growth of the fetus. The other cause, which is also, if you want me to, from what I've explained to you, what I've enumerated, the other common causes would be basically the infections, which are common factors. And before I go further, what is also interesting is that most women, especially in primary pregnancy loss, will have lost a pregnancy and they may not even know that they were pregnant. one of the common things that somebody may have a suspicion that there's something is that probably your menses delayed by a week or two. Then the periods, you get your menses. Most of these women actually had an early pregnancy, and maybe there was the growth of the fetus, the embryo was compromised, and now the uterus is shedding it off so that that comes out. The third common factor amongst our women here would be what I mentioned as the mechanical causes, where there's a problem within the uterine lining, a problem within the cervical canal, then those ones you can be able to take care of. What I mentioned as the connective tissue disorder is also quite a common thing, and this cut across globally because it is one of those things which you must have a high index of suspicion to be able to know that this is a possibility. Look for it, and then you can now be able to determine what are you going to do so that you can be able to prevent it happening. So this gives you an overview of some of the common things we see within our setup. But remember, a miscarriage, sometimes it's so unique in each and every woman such that somebody may have recurrent miscarriages, but each and every miscarriage may have a different causative factor, not necessarily that it will occur in the subsequent pregnancy. And also, if somebody has had one miscarriage, it does not mean that she cannot get subsequent pregnancies and you carry the babies to term, and then you have a baby to take home. So, you know, as obstetricians, we always say a successful pregnancy is determined by the take-home baby rate. If a mother delivers and takes home a baby, that's your success. It is not that how many women were pregnant. For a woman, if you're pregnant and it was a desired pregnancy and you have nothing to show cause for, meaning that you have no baby to take home, then that was a lost cause for you and brings a lot of psychological stress to the women.
Right.
Yes.
Doc, you talked about the primary miscarriage, which is a recurrent miscarriage, and you said when it's one miscarriage, then there's no cause for alarm. But we have women out there who've never had a chance to carry a baby home. Recurrent miscarriages, still the causes that you're talking about, are they the common causes? And then another question is on the age factor. You know, does the age of the woman, let's say we have teenage pregnancies, we have late pregnancies, are they some of the risk factors for miscarriages?
Good question. Let me just clarify something. When you classify miscarriages as primary, secondary, and tertiary, it doesn't necessarily mean that somebody with primary classification of a miscarriage is the one who will have a recurrent pregnancy loss. No. You can have recurrent miscarriages. It can still be primary, can still be secondary, can still be tertiary. It still cuts across through all those. Now, you asked me an interesting aspect about the age factor and miscarriage. We know that women in their teenage, the late teens, up to the age of about 20, 24 years of age, you'll find that the chances of having a miscarriage, if you look at it globally, works out to only about nearly 6% only. If you go down the road, if a woman is of the age of 45 and above and she gets pregnant, she has got a 75% chance of a miscarriage. A woman in her 30s has a 25%, almost 45% chance of a miscarriage. So you see, as the age factor comes in, the woman has got a higher chance of having a miscarriage.
And what's the explanation for that?
The interesting thing here is this. Let me explain something here. You know, for a long time, everybody used to say, or there used to be an advice to the women that over the age of 35, no woman should get pregnant because of so many risk factors. But we know in the setup we are in, we have career women. Women start getting starting their families from the ages of 30 and above. That's when they are finished their schooling, they are now steady in life, they have got steady job. So it's a common thing. So still when a woman is at the age of 35 and above, we know that conception rate starts going down, miscarriage rate starts rising.
Right.
Okay. That has a lot to do with the aging factor of the ovaries and the eggs, the follicles. Then you have the second thing is you have the aging factor of the endometrium. So all these work in tandem to reduce the fecundity, meaning the ability to conceive, and also increases the woman's chance of having a miscarriage.
Right.
So when you go over the age of 40 and above, what we refer to as very advanced maternal age, VAMA, then your chances of a miscarriage is much higher than that woman who is younger. So those are why the age factor comes in, because of the functions within the ovary and the female eggs, because they grow. You are getting towards the time when now you are getting towards going to peri, then eventually to menopausal state. And also now the other factor of the endometrial lining effect starts coming in, because the thinning effect comes about because of the hormonal changes which sets in as you grow older.
Right.
Yes.
Yeah, and still on the causes for pregnancy, you've mentioned something very interesting on the male factor contributing to that. Just put it clear that we may understand that just the way you're saying that for female, the more you age, the higher your chances of having a miscarriage. So for men, is it the same way? The more they age, the higher the chances, their contribution to women having miscarriages? Is that what you're clearly saying?
That is true, because this is a new phenomena which is coming in, because for a long time, people used to think that the male is as good to go anytime. But we know that as the age sets in, then you find that you have chromosomal abnormalities which are realized in the sperm, because the sperm is also aging as because, you know, the manufacture, where the sperm development takes place, the age factor also gets into play, such that you will not be able to get as an ideal spermatozoa as you had when you are still in your prime. So you are more likely to have chromosomal abnormalities within the within the embryo, which subsequently may lead to increased chances of pregnancy loss, which we are looking at here is the same thing as saying there is a miscarriage. So that male factor is there. It is not as high as what you would get in the female factor, but it is something which people should know that it is a fact to be realized.
Right.
It looks controversial as it is, but that is the facts which are there.
All right.
Yes.
Yes, and we want to have a look at some more tips on the causes for miscarriages. But when we come back, we also want to give you an opportunity to call us live. Use the number 0791 478 990. We'll all You're still watching My Doctor Show. Welcome to the second and the last part of the show. Remember, this time we are welcoming you to call us live using the number 0791478990. Use the hashtag My Doctor to tweet us at Ebru TV Kenya on Twitter. And once again, joining me is Professor Omondi Ogutu, guiding us on to learn more about managing or how to prevent miscarriages that we see happening. And welcome back.
Thank you.
Yes, but just before we want to, next we want to have a look at some of the warning signs for miscarriages, sorry. But just before we have that discussion now, I think it's time for our home remedy segment. Let's just have a look at what we prepared for you. Yes, and welcome back. So, Doc, a time for our discussion once again. And first, thank you so much for making us understand what could be the common causes for miscarriages. Let's now get to talk about the warning signs. What are the warning signs for a pregnant woman that you see? I think these signs, they are indicators to one getting miscarriage.
Good. One of the, if you want to look at what would be the warning signs, number one, some of the women who have a miscarriage may not know that they have had a miscarriage. That's one. And who are these who may not know that they have a miscarriage? You are pregnant. You thought that you have missed your periods. You have done your pregnancy test. You know you're pregnant, and you hope that the pregnancy is growing. Mm-hmm. But maybe something has happened, and the baby is not, the fetus is not growing. Mm-hmm. It's only later on, maybe you go to see your doctor, then you are told, no, there's nothing here. Maybe you have an ultrasound done and you are told, no, there was a pregnancy, but it is not growing. That's one group. There's the second group whereby you find that you are pregnant, you have got the early signs of pregnancy, nausea, vomiting, breast tenderness, and you just have those mood changes. And then after maybe a few weeks, you find that those signs just disappear. Mm-hmm. And you start feeling normal. Those are signs you should be able to watch out for. Mm-hmm. Or the classical one is where one is pregnant and then you realize that you are spotting or you start bleeding. Normally that is an overt sign, which is what makes women run to their care providers that I'm pregnant but I'm bleeding. So something is wrong. Those are the classical women who actually present to a health facility that I'm pregnant, but there's something is not right. Those are the ones you'd be able to see coming to a facility earlier on, but the two groups whom I've mentioned maybe would decide that maybe let me go and be checked, or when you go for your routine check, then you find that something actually is not happening, and mm-hmm. therefore you may have lost the pregnancy.
And maybe, Prof, before we proceed, can I cut you short? We have someone who's calling us. We can hear what they have to say first.
Thank you.
All right. Hello.
Hello.
Hi, Valentine.
Hi.
How are you today?
I'm fine.
Okay, your question, please.
Nilikuwa na miscarriage 2015. Mm-hmm. Mimba ilikuwa ya miezi 6. Mm-hmm.
Yes, I can hear you, Valentine. Go ahead.
Mimba ilikuwa ya miezi 6. Nikakuwa na miscarriage. Alafu nyumba ya mtoto ikatoka, yani njia ya mtoto ikafunguka.
Okay.
Sasa nikafanyiwa CS. What happened?
Mm-hmm. Okay. I think she needs to understand what happened.
That's because from her question, she said that she was 6 months pregnant, who could have been either 24 weeks or 27 weeks. Mm-hmm. And then she went to hospital and she was told that njia mtoto imefunguka, meaning that there was cervical dilatation, then a cesarean section was done. What she has not told us is what was the outcome. Did the baby survive or not? And probably one of the reasons which might have made the cesarean section be done was because it was a premature baby, and maybe the doctors had made a decision that it would be better off to deliver this baby mm-hmm. because of prematurity. Mm-hmm. So in her case, the correct terminology you would be able to use is that if the baby was, if decision was made to deliver the baby by a section, most likely that baby was alive. Therefore, the correct terminology should be that she had a preterm birth, mm-hmm. premature delivery. And if the cervix had started opening, possibility that maybe more history, if she goes to a care provider, would be able to know whether, was it the first time it happened, mm-hmm. and what was the scenario which prevailed, and is she somebody whom would have benefited for what you call cervical sacrilege, meaning that you put a stitch around the cervix. And she has not told us whether it happened in 2016. Has she planned to get another baby or not? Or is it that she has a problem of conception? Mm-hmm. And therefore what should be done is 2 years down the line. Mm-hmm. Yeah. But definitely it seems like there's something which precipitated that preterm which made the doctors decide to do a preterm delivery by assist delivery. Yeah.
All right, we can finish up with the warning signs.
Yes. Now, so for the other warning signs is that you may find that because a woman maybe in the later, early part of the second trimester, maybe 14, 15, 16 weeks, then you realize that the baby, the uterus is not increasing in size, and you start wondering what is happening. You find that you are not increasing in weight. Then those are some of the things which tells you, because on a normal circumstance, the woman should be able to gain weight during the course of her pregnancy.
And Doc,
And
I'll
on-
cut you short once
yes.
again. We can pick on one more
Thank
call.
you.
Okay. From Kakamega. Hello?
Hello.
Hello, hi.
Hi.
Okay, your question, please.
Nilikuwa nauliza kuna rafiki yangu akiwa na mimba ikifika 5 months anakuwa na miscarriages. Nini inaweza kuwa mbaya?
Haya, asante sana.
Ikifika 5 months.
Okay.
Good question. And you know, when somebody gives you an information which is on somebody loses a pregnancy at a gestation of 5 months, you know, for us 5 months it could either be 20 weeks or is it 24 weeks. So it would be, the best thing would be to have a care provider, go to a gynecologist, there are several in Kakamega, to have a review to be able to determine what could be the cause here. Now, the causes can be several. Is it because of a mechanical issue, as I had said? Is it that there's a cervical factor? Is it a problem within the uterus because of accommodation? The uterus does not enlarge. And then there's another aspect which I had not mentioned earlier on. Is it that we're having compromised circulation within the placenta, such that the baby is not adequately nourished? So you get what we call placental hypoperfusion, meaning that there's little nutrition through or blood flow through the placenta, and therefore this baby does not grow, and therefore you lose the baby because of what is happening.
Right.
Or could it be that this mother has got abnormality in the growing fetus, which when you reach 5 months, it gets compromised? So there could be several other reasons, and the best thing would be to investigate, and usually the causes will fall within the 12 causes of a pregnancy loss. So it has to fall within that group.
Okay,
And therefore you treat depending on the cause. Yeah.
And maybe you can hear from Nancy from Naivasha. Hello, Nancy. Hello, Nancy. Nancy. Can you hear me, Nancy?
Hello.
Hello, Nancy. Hi.
Hi.
Okay.
Hello.
Yes, I can hear you. Just reduce the volume of your TV. Then, yes, then you can
Hello.
get. Nancy,
Hello.
just reduce the volume of your TV. Then you can get me clearly, Nancy.
Hello, I'm getting you.
Okay, go ahead.
Okay, mimi nina swali. Hello.
Yes, I can hear you, Nancy. Go ahead.
Niko na swali.
Mm-hmm.
Last year nilikuwa na boarding 16 weeks.
Okay.
Alafu ikatoka. Ikableed ikatoka. Tena vizia niko naye but imeanza kubleed, so sijui swali ni shida ni nini.
Okay, Nancy. Sorry about that. You've heard what Nancy is asking.
Yes. She was pregnant, she started bleeding, and she lost the baby. One of the possibility of what could have been happening here could be several. One of the things is that she could have been there could have been a separation of the placenta, where the placenta is implanted, then there's detachment of the placenta, and when you start bleeding, therefore you find that the placenta gets detached from the wall of the uterus where it is implanted, and therefore obviously you end up losing the baby, because now the placenta, which is supposed to provide nourishment to the baby, is now lost. And as you bleed within the interface between the uterine wall and the placenta, that clot makes the placenta separate, and you lose the baby. Some people, when that happens, you even go into labor and you end up having the pregnancy being lost. So that's quite a common thing, which tends to as one of the common causes of the pregnancy losses. Yeah.
All right, and Doc, had you concluded with the early warning signs for miscarriage?
Now,
because it's important.
yes, I
also
talked about the weight gain, and also the fact that the uterine size does not grow. The other factor would be that some women, depending on whether you have had more than one baby before, you start getting what we call quickening movement of the baby. They start perceiving fetal movement sometimes when they're about 16 weeks, 4 months, or 20 weeks, 5 months. Then you find that a baby which was playing, the baby stops playing.
Okay.
Then that tells you that there is a problem in this pregnancy.
Okay, and Doc, pardon me. Allow me to cut you short once
Look,
again.
proceed.
Okay, we have Anne is on the call. Hello, Anne.
Hello,
Hi, how are you?
I'm fine.
Okay, go ahead with your question.
I had a miscarriage 3 months ago, and now I'm preparing to get another pregnancy.
All right.
And when I have my menses,
Yeah.
and when I have my menses, one side of the tube is aching. I have pain.
Okay.
So I'm fearing whether if I get another pregnancy, whether that one will cause it to come, to be terminated.
Okay, thank you so much for your concern.
Okay.
Yes, what I'm getting from most of the callers is exactly what I'd mentioned at the beginning, that a miscarriage or a pregnancy loss for a woman is a very devastating thing, which we know as obstetricians, we deal with that every day. And no amount of words, no amount of medication will be able to heal this woman. The nearest or the closest to a healing process she can get is for her to get another pregnancy and carry that pregnancy to term and deliver a baby.
Right.
That's the closest to a treatment she can get. And as the last caller has just mentioned, that she's worried that if she gets pregnant again, will the same occur? The best course of action would be have her provider look at her to try and ascertain what could have been the cause in the previous pregnancy. And if you can be able to elicit what was the cause, then you work with the patient and try and solve what could have led to the previous pregnancy loss so that the same does not occur again. Because if you don't work with a woman so that you manage what her problem was, then even the woman, when she gets pregnant again, she'll not be convinced that she'll be able to carry that pregnancy again. And there's no point in her going through a pregnancy and she's already not sure of whether am I going to carry this pregnancy to term or not, because it brings untold stress to the woman, which as a clinician you must address right from the beginning, even before the conception takes place.
Okay. And we want now to look at how to manage a pregnancy for a woman who is pregnant, because you've already told us the chances for miscarriage. You say that as we get older, then our chances of miscarriages increase, and also some of the conditions that you've talked about. But now we want to look at how do we manage pregnancy for any category at any age, either teenage up to the old age. How do you manage that? But before that, I understand there's someone who is on call right now. Hello, Cynthia? Hello? Hello, Cynthia? Cynthia, can you hear me?
Yeah, I can hear you.
How are you today?
I'm cool.
We are fine too. What's your question?
Hello.
Yeah, just reduce the volume of your television set, then you will get me clearly.
Okay, nimereduce.
Okay, go ahead now.
Okay, swali yangu ilikuwa ni nilikuwa na ectopic pregnancy.
Okay.
I got operated.
Yes, go ahead. Nakusikia.
So nilikuwa nauliza hiyo inaweza affect any chance, by any chance inaweza fanya niko na complications afterwards.
Okay, asante. You can answer Cynthia with this. Someone else who was asking, for her she had an ectopic pregnancy, so she's asking the chances of her getting another baby. There was someone else who was asking about fibroids. She's living with fibroids. The other pregnancy was terminated and now she's thinking of getting pregnant. Will it also affect the development of the child?
Okay. How do you manage women with fibroids and how do you manage women who have had an ectopic pregnancy?
Right.
The fact that a woman has had an ectopic pregnancy does not necessarily mean that you cannot have another successful pregnancy. Because nowadays we do conservative surgery, especially if it is unruptured, meaning that the tube has not opened up. You can be able to do conservative surgery such that you can be able to conserve that tube so the woman still has got both her tubes and can still be able to get pregnancy. Although there's still that small chance of maybe up to about 10% that you may still have an ectopic pregnancy again. So that is always a chance which is always there. So the fact that you have had an ectopic, so if you get pregnant, then it should be followed up right from the beginning, and you can be able to pick up through ultrasound imaging if the pregnancy is in the uterus or it is another ectopic again. And if it is, you can be able to institute early management to correct that so that the tube does not rupture. Now, for somebody who has had a fibroid, it's interesting if she says that the pregnancy was terminated because you have a fibroid. Normally, we will not terminate a pregnancy because you have a fibroid. What would happen is that if you have a miscarriage or a pregnancy loss because of the fibroid, then you'll be advised that before you get your next pregnancy, have those fibroids removed.
Right.
But then, women with fibroids can still be able to get pregnant, deliver normal pregnancy, even get all the family size they desire without having to have an intervention. So the message here is that the fact that a woman has a fibroid does not necessarily mean that you must be operated on before you get another baby, unless there's a complication due to that fibroid, which is compromising your chance of pregnancy or your chance of carrying that baby to viability.
Yeah, and we have Antonina on the line from Nairobi. Hello.
Ya, nilimiscarry last year June.
Okay.
Ya mwezi wa sita. Ya nilipatikana ati nilikuwa na high blood pressure, alafu mtoto alikuwa na abnormalities.
Okay.
Sasa nikamiscarry. So now niko pregnant tena. Sasa najiuliza naweza miscarry tena cause sahi niko like 5 months.
Okay. Asante sana.
Yeah.
And sorry about that. Yeah, she's
My
worried.
answer to her is this. I hope she's attending antenatal clinic somewhere where there's a competent provider. The fact that she had a high blood pressure in the last pregnancy, she has a very high likelihood that she may have blood pressure again in this pregnancy. And the symptoms may worsen in subsequent pregnancy. So therefore, my only prayer is I hope she's being managed. And if she's being managed, you can still be able to get a successful pregnancy even if you have got high blood pressure. The only risk is you wait until you go to a hospital or you go to be seen by a care provider when now your pressures are very high such that management has to be instituted to deliver that baby, because she says she's now 5 months, so that you are, the complications which might arise in you are arrested, which involves compromise of your renal function. You can get your kidneys failing. You can get a problem with your heart function. You can even get bleed in the brains. So that's why a high blood pressure in pregnancy, we consider that as a silent killer. And if you look at some of the causes of maternal deaths in this country, high blood pressure ranks number 3. And we consider it as a very, very major condition, medical condition in pregnancy, which we manage aggressively to be able to get a live baby and a live mother. But if the life of the mother is at stake, we'll always be able to deliver that or terminate the pregnancy depending on the gestation If it is at the age of viability, you deliver that baby, even if it is premature, so that you save the life of the mother.
Okay.
Yeah.
And Doc, we don't want to end the show before we talk about management and prevention
Yes.
for pregnancy.
I think that is a very, very important aspect. And that's one of the babies I deal with every day. How do you manage women with recurrent pregnancy? The first thing is try and ascertain what are the causes. From the causes I enumerated, you carry out your tests to be able to determine what are the causes, and then you start treating them. One of the things I need to mention is that to manage recurrent pregnancy losses is very expensive. And especially the ones where you have got this immunogenic aspect, because you put them on various regime of medication. There's some you have to put them on steroid medication, and you also put them on blood thinners. You also put them on anti-immune medications, which you give through the veins. And some of these drugs run into thousands and thousands of shillings. But with correct instituted management, these patients are able to carry pregnancies to term. And there are so many women out there who will tell you that when they report to their caregivers early, these pregnancies are managed. Provided that correct things are done, you should still be able to get your pregnancy. You should be able to carry your pregnancy to term. So the message out there is that a woman who has had a miscarriage should not give up hope. Know that you can still carry your baby and deliver. And there are many who can tell you about their stories of their lost 3, 4. They were managed, and they have had several other babies until they have achieved their desired family size.
Right.
So women should not look at myths that, oh, you did this, that's why this has happened. No. Go to an obstetrician who will look at you and treat you, because it needs a lot of patience, it needs a lot of indulgence of management so that you can be able to get the baby. Forget about myths. Go to hospital, you'll be treated, and you'll be able to get your baby.
Right.
Prevention. One of the prevention, if you know that you are somebody who has got those factors who may lead to a miscarriage, or you have had a family member who has had a miscarriage, you are somebody who has got fibroids, you have had a history of, you have had a miscarriage before, then even before you plan to get pregnant, go and be examined by an obstetrician, gynecologist, so that they can be able to ascertain, do you have a problem which should be managed before? There are some of those patients who have got what we call like connective tissue disorders. There are medications they are put on so that you can reduce the sensitivity of the condition you have,
Right.
so that your endometrium will be receptive to the implanted ova. And the embryo will be able to grow.
Right.
Some of the drugs which are used are fairly expensive, but nowadays at least there are cheaper versions which are now available in the market for those who know how to use them. And you'll be able to find that women get their babies and they have got somebody to take home. Yeah.
All right, and my director tells me our time is up, but there was someone really wanted to understand why she went for scanning during her 10th month of pregnancy, and the baby was found that the baby was already dead. Maybe what could be the cause of that?
10 months, that means that that was a baby which was due for delivery?
Actually, yes.
10 months or
It's
10
supposed
weeks?
to be, I don't know, she said 10, I think it's supposed to be
10 months,
9
that
months.
means that that's a baby
Yeah.
who is now ready for delivery.
Yes.
Because, okay, for the lay people, will say it's about 10 months is about 40 weeks.
Yes.
You know, there are so many things which can happen in a pregnancy. And anything can lead to that. And the commonest problems which you find in those situations is that the baby could have had maybe an abnormality, either in the heart or anywhere else.
Actually,
which
she
maybe
says the baby had head injuries.
head injuries.
Yeah, maybe
Well,
what
that
could
means that that baby had got congenital abnormalities in the brain, And those could have been either a hydrocephalus or an anencephaly or any of that. So my question would have been probably was that her first ultrasound? Because some of those complications, if you do an imaging investigation, ultrasound, they're usually picked much earlier, and the mother can be advised that here we're having you are carrying a fetus which will not be compatible with life, or we need to deliver this baby early and then see whether can this baby survive or not. Mm-hmm. So that is the essence of early and continuous antenatal care.
All right.
Most of our ladies believe that once you're pregnant, I'll wait, and when I'm due for delivery, I walk into a hospital and deliver. So many things can go wrong anytime. Pregnancy is a journey, is a story. And like most people tell you, when you're pregnant, you have got one foot, you can be okay, the other foot, the baby may not be okay. Mm-hmm. So when you have that continuous interaction with your care providers, then you will be able to know what is happening to your baby, what is happening to you, so that your expectations will be managed. You'll know when to expect to deliver. And in some of these scenarios, you'll find that your doctor may advise you that I think we have a problem, we may deliver early. And this is the essence of good antenatal care, mm-hmm. where the woman and the doctor both manage the pregnancy together.
Okay.
Yes.
Professor Omondi Ogutu from the University of Nairobi School of Medicine, thank you so much for coming to my doctor show today. It was really important having you, right?
Thank you. See you next time.
All right, and that's all the time we had for the show today. Thank you for your contribution. Thank you for your calls. And remember, this conversation doesn't end here. You can always use the hashtag #MyDoctor to talk to us on Twitter @EbruTV Kenya. The show continues next week, same place, same time. I'm Purity Musel. Good time.